Go ahead.
Yeah. All right. Okay. My name is Hind. I'm a cardiology registrar, and I'm going to present a case. And I will make it like an interactive case presentation. So I might need to stop after some certain slides to ask the panel members their opinion. Right. Okay, so I have no disclosures. Right. Okay, so our case is about a 75 years old lady who was brought to the accident emergency department by the ambulance crew with history of 3 episodes of collapses. And these episodes actually happened so quick and with quick recovery. And after the last episode, she sustained a minor head injury. She also had a 1-week history of progressive increasing shortness of breath and increasing leg swelling. She's a non-smoker, non-alcohol consumer. She walks a good distance on flat, but for the past 12 months, she was struggling with shortness of breath on stairs and on inclines. She lives alone and normally independent, and she suffers some anxiety. And these are her medications. She was on furosemide and some salbutamol inhaler. Probably this is due to her symptoms of breathlessness over the last few months before her presentation. So she had an echo in 1 year prior to her presentation. And I'm just going to stop here to ask the panel members to, if there's any comment. Anyone from the panel would like to comment on this echocardiogram? This is an echocardiogram of this patient, which was performed almost a few months or a year prior to her presentation. Okay, any comment? Right, okay, so
maybe we can ask Dr. Safa, maybe you can.
Dr. Safa, do you like to comment on this echocardiogram? Do you have any comment on that? I have 2 views here and maybe another view here.
So if you go back to the original.
So I'll go back to the original one or the previous slides.
So you can see, so I'm not an imaging specialist, but you can see in this, on the right-hand side is apical 4-chamber view. You can see that the main striking feature here is that the right heart appears to be larger than the left, so the right ventricle is dilated. The right atrium, you can see that there is some bulging from the right atrium into the left atrium, suggesting some right-sided increased pressures. The LV function itself looks relatively reasonable. It may be a little bit underfilled, the left ventricle. The right ventricular function is a bit tricky in those stills to comment on, but perhaps it looks like there's good radial function and perhaps reduced longitudinal function. And on the left-hand side, you can see evidence of what we call a D-shaped septum. That's the interventricular septum, indicating right-sided pressure or volume overload.
Okay, good. So I actually agree with what you've said, and just to add here that the color flow and the across the tricuspid valve shows here probably mild tricuspid regurgitation. The Doppler here is not quite clear, but from the report, it was reported as a mild TR, as I mentioned, and with an increase of pulmonary artery pressure, estimated probably like 55, possibly up to 60 millimeter mercury. They reported the LV function as mildly impaired, but I do agree with you, Ahmed. I think it appears a normal contractility of the LV function, of the LV cavity, and the RV function is, as you mentioned, is dilated, and also mentioned here in the report, with reasonable RV function as well. Right, so in clinical assessment of this patient, as we can see here, when she presented, she was saturation was low, she was hypoxic, 89% in room air. Initially, her blood pressure was low and normalized after some IV fluids. She was not particularly tachycardic. She was afebrile and she was using 5. On examination, the rest of our examination showed that she was having like cyanose and cool peripheries. Her JVP was markedly raised. The examination of the precordium was interesting. She had a palpable and loud P2 with a right parasternal heave and a pansystolic murmur at the left lower sternal border. The chest was clear, and she had a pitting edema up to the knees. The abdomen examination was unremarkable. She didn't have any focal neurological signs, and she had small swelling over the right posterior aspect of the head. This is following her fall due to her collapse, one of her collapses that she had prior to presentation. So this is the 12 leads ECG of this patient. Maybe I show this maybe more clearer. And at this stage, I will stop here for the panel members to comment on the ECG.
Hello.
Yes.
A patient in the ECG shows that she's in sinus rhythm. So got right walk. So got right ventricular, most probably right ventricular strain. There's a widespread T wave changes in the anterior leads, which goes with right ventricular dysfunction, with right ventricular branch block, and she's in sinus rhythm. Overall, the heart rate is about 90, less than 100.
Okay, Ahmed, do you like to add anything?
No, I think that's pretty good. I think maybe there's a almost first degree heart block as well, but apart from that, yeah. I think
so. Shall we say this is like it looks like trifascicular block, or is it right ventricular hypertrophy?
I think I agree with Dr. Badri. I think it is right ventricular hypertrophy. You see, there's right axis deviation as well.
So yeah, there is a right axis deviation and probably right. It resembles right bundle branch block, but it could be mainly the right ventricular hypertrophy, and we have a prolonged PR interval or first degree heart block. Okay, so this is the chest X-ray. Anyone would like to comment on this chest X-ray from the panel? Dr. Badri, Dr. Safa, or Dr. Ahmad?
Right, the chest X-ray shows the heart is enlarged, so We don't know whether this is an AB or or portable X-ray.
Yeah, this is an AP view. Actually, this is a portable AP view.
Right. So there's a cardiomegaly, there's an enlargement of the heart, and there's an element of pulmonary congestion. You can see a lot of of pulmonary vasculature in the lung fields. The right side of the heart, I don't know whether that is the right left ventricular, left atrium dilatation or not. Very difficult to say it on this one. I can't see the pulmonary artery. It's slightly dilated, but more than that, I don't think there's anything. The costophrenic angles are free, so there's no pleural effusion.
Right. Okay. Any other comment from other panel members? Right. Okay. Actually, I agree. It's an AP view, but the heart appears to be a little bit enlarged. Actually, the report they reported as clear lung fields. They haven't reported any evidence of congestion, and obviously there is no consolidation in the lung fields. So these are her blood gas result. As we can see here, it shows hypoxia with compensated metabolic acidosis. As you can see here, the lactate is quite high, 6.7. And for the blood test, because it's a busy slide, I'll just leave the abnormal investigation. So for the full blood count, you can see here the hemoglobin is elevated to 174. The white cell and neutrophils are raised, lymphocytes slightly low, hematocrit also elevated, and CRP is not particularly high. There's just mild renal impairment. There's some mild liver function derangement. Lactate, as the blood gas shows, is elevated from the plasma, and maybe her blood glucose is slightly raised. So she was transferred to the cardiology ward, and shortly after her transfer, she had another episode of syncope, which happened after she being to the toilet while sitting in the chair. She had a brief episode of loss of consciousness and recovered spontaneously. So at this stage, and after all this information, what do you think could be the diagnosis of this patient? Anyone from the panel members would like to give us an opinion? Dr. Badri, Dr. Safa, still with us, Dr. Safa? Okay. Any thoughts?
Yes. Hello.
Yes.
This lady, and obviously got a right heart failure. She became hypoxic. There's a loss of consciousness or syncopal attack, which could be related to her rhythm abnormalities, like having a first heart degree block and having a tridental branch block. It had been aggravated or due to the hypoxia by itself. I mean, there's an evidence of arbitrary. I mean, the pulmonary hypertension could be also cause of a syncope or syncopal episodes, and all her symptoms may be due to the right heart failure, with and without any changes in further in the rhythm.
I had a question as well, Dr. Hind. Did the patient have any hemodynamic compromise? And has anyone set the oxygen saturations during mobilization?
So during, you mean when she was transferred to the, without oxygen, she was hypoxic, and she, I think she was maintaining saturation on maybe 6 liters, about 93% when she came in from the, because in room air, she was desaturating, her saturation goes down to 80, 88, 83, I think. And initially she was hypoxic when she presented to the A&E.
And
So,
you said she collapsed while she was walking to the toilet, did you say?
She was walking to the toilet. No, she came back. She was sitting in the chair, and then she had this episode of brief loss of consciousness.
Pulmonary
This is after she came back.
With an acute setting, I don't need to give the game away quick, but I think it's acute setting with a very hypoxic lady like this with clear evidence on her echocardiogram showing that she does have evidence of right heart strain pattern. On her ECG also, her echo showing that the pressure overload, that she had a collapse. I will probably put a massive pulmonary embolism, my first differential diagnosis. And I think that's exactly what Dr. Muhammad Badri is pointing for.
Okay, so basically, as you mentioned, obviously from the background of this patient and the symptoms, the signs, and her presentation, there is an underlying pulmonary hypertension. But obviously, we need to exclude other emergencies like cardiac tamponade and pulmonary embolism. And also because of our ECG and the syncopal attacks, we would like to rule out possibility of heart blocks and also possibility of a shunt given that degree of pulmonary hypertension. So, and following that, she had an urgent bedside echo. And here are the images. And I have more slides just going to show. Anyone from the panel would like to comment on that? Is Dr. Safa still with us?
I think Dr. Safa, she got ongoing clinic and she's used to join us just between the patient. I will just add, I think, one comment and then I will leave Dr. Ahmed also to make his comment. So while I'm making my comment, I would like just to get Dr. Safa back. I think she's with us at the moment. And Dr. Safa, would you like to add any comment on this echocardiogram?
So
I think Dr. Safa is joining us. I guess I'll leave Dr. Safa to
Can I make a comment while Dr. Safa is coming back? I think the compared with her previous echo, it is very obvious actually her right side is becoming more dilated. Her RB is very dilated now. And we just had an observation which wasn't seen before. She has mild AR. It's not, I don't think it is any of no importance for us in these settings. But I think probably this patient might have a chronic thromboembolic disease, and now he got another thrombus, and this is an acute pulmonary embolus, probably putting more strain on the right side of the heart.
Okay, right. This is further images. Yeah.
Dr. Safa, would you like to make your point?
Dr. Safa, are you? Yeah. Okay.
Thank you, Dr. Hind. Now
do you want to add any comments? Yeah.
Yes, that what I would call D-shaped septum. In the initial images you've seen, I'm sorry, it was not my day today, just in and out. The first images you've shown, there was a comment from Dr. Adlan that there was a D-shaped septum. And that is what I call a D-shaped septum. Now this is a D-shaped septum. And the difference between the D-shaped septum and the no D-shaped septum is walled apart. Now this is a hemodynamically compromising. This is why this lady is symptomatic with whatever symptoms you're giving, dyspnea, collapse, shortness of breath, whatever, because this is denoting that the right side is dominant, both volume and pressure. Now this is a worrying echo that you're seeing. Yes, the initial images have shown, a couple of images or 4 images I've seen earlier with the clips. Yes, the right side was dilated, but this is the right side dominance, volume and pressure on this, the ones you're showing now. Definitely, this is, I would pick the comments passed by my colleague, Dr. Abdullah, as whatever is happening initially, whatever the cause of the right side dilatation, with a secondary to her left side, probably I can see some degree of left ventricular hypertrophy. So there was whatever this hypertension due to
I think we lost Dr. Safa voice. The voice is not clear. The sound,
I think
Dr.
so.
Abdelaziz?
I think we can't hear Dr. Safa clearly. Dr. Safa, can you hear us?
Right side.
I'm sorry, Dr. Safa. I don't think the voice is not clear at all.
Hello.
Yes, now, yeah. The sound was like broken, was cut off for some time, so we could not hear your last comment.
Yeah, just continue, Dr. Safa.
I think it's broken again.
Yeah, I'm sorry, Dr. Safa, we can't hear you. And do you want to continue your case?
Okay, so I agree with all the comments given by Dr. Abdallah, Dr. Safa, and this is obviously a massively enlarged right heart with a severe tricuspid regurgitation.
I would quickly repeat what I've said. Okay, I would quickly repeat what I've said.
Okay, yeah.
Yeah, this.
I think we got a problem with the sound here. Right. Shall I proceed now? I think we've lost the connection with Dr. Safa.
If you just carry on.
Yeah, right. Okay. So this is the IVC. It's not particularly enlarged, but there is lack of respiratory collapsibility. And here, this is just an image for the intra-atrial septum to rule out the possibility of a significant shunt. And this is the report, as we can see here. All what we have mentioned. The pulmonary artery pressure estimated probably between 80 and maybe up to 90 millimeter mercury. And there was some trivial precardial effusion in addition to what we have mentioned. But of course, the striking abnormality, as we could all see, the severely impaired and severely enlarged right heart. Right, so following that, so this patient was put on monitoring, an urgent CTPA was requested, she was given IV fluids, and because of the history of the, because of her ECG and the possibility that she could have bradycardia, the plan was to consider isoprenoline if there is any evidence of slow heart rate, and of course COVID-19 swab. Right, so she had an urgent CTPA, and as I don't know if it's clear, but anyone would like to comment, or shall I just, maybe it's just not in the lung window, but anyone from the panel members would like to comment? Dr. Abdallah, Dr. Adlan, I think we lost Dr. Safa.
It looks like there is actually a filling defect, especially on the right pulmonary artery. It seems like also it is extended up to the common pulmonary artery, and I cannot see anything in the lungs, but probably this might be a contributing factor to her presentation. And I think it confirmed actually she has pulmonary embolus for sure. And I think if we can let us just go through it to see just the size of the heart as well. Or
there's maybe two images only. I'll just go to the yeah, 2 images. I don't have further images here and they that I can show, but this is the report. It was reported as you mentioned, as you said, Dr. Abdullah, this hypodensity, it's a linear hypodensity within the right main pulmonary artery, and as you said, it's also extending to the main pulmonary trunk, consistent with a pulmonary embolus, and there was also extensive bilateral segmental and segmental pulmonary embolism with an evidence of right heart strain, as you mentioned. They just mentioned some hiatus hernia and maybe small right pleural effusion. So, so obviously now the diagnosis is clear, and it was discussed with the respiratory team, and the diagnosis was made as acute pulmonary embolism with underlying chronic thromboembolism or chronic thromboembolic pulmonary hypertension. The decision or the plan was to start her on therapeutic low molecular weight heparin, and with the option of thrombolysis if she became hemodynamically unstable. And she remained in coronary care unit.
Well, Dr. Hind, why? I mean, this is a classical case. I mean, for thrombolysis. I mean, we have seen her echoes. The right side is dilated, and there is strain, and also her hemodynamics, her blood pressure is low. I think probably she is the right patient for thrombolysis unless there is contraindication. And the other option will be also maybe for her age or whatever, she might not be candidate for systemic thrombolysis, but another option will be for her local thrombolysis using echoes. And we have a couple of patients, more than 8 cases actually, we have done them for this kind of patients that are very successful with very likelihood actually of getting the systemic side effects of thrombolysis. So I think it's something that should be considered, and it is indicated unless there is other causes to make her not a good candidate for thrombolysis.
Yes, I agree with you. Actually, she's a suitable candidate for thrombolysis, but at that stage, that was a plan just to keep her, under monitoring, and if she became unstable, then that would be considered. That was the following discussion actually with it was between the cardiologist on call and the respiratory team at that time. So generally, she remained reasonably stable. Her blood pressure was above 100 until midnight when she dropped her blood pressure, and she was not passing urine actually, and she was given some IV fluids. And later on, she was reviewed by she was referred and reviewed by the critical care team. And actually, the team felt that she would not be an appropriate candidate for escalation. But again, the discussion was towards that, to consider thrombolysis if the blood pressure continued to drop. Then this has been discussed with the patient, who I think she was, for some reason, she declined thrombolysis, and mainly because she was anxious and a little bit worried about the complication of thrombolysis and the bleeding. And then at that stage, the DNR was discussed with her as well, and she was in agreement that she would, actually her wish is not to be resuscitated at that stage, and accordingly she was considered as not for escalation, and she was kept under monitoring. And still, if she changed her mind, the plan was to still to consider thrombolysis, but the patient actually declined that option.
It was the patient options, right?
Sorry?
was the patient option. The patient
The patient, yeah, the patient, yeah, at that stage when it was discussed with her, she declined thrombolysis for some reason. I think she was just worried about that, about the complication, about the bleeding, about the risk of thrombolysis. That's what I understood from her, because I saw this patient
sorry,
next
Dr.
morning.
Do you hear me? Can I
Yes,
stop
I
you
can hear
here?
you now.
Right. I need to clarify this point because, to be honest, I feel I'm not happy at all about this patient management so far, if you allow me. The patient came with every good parameter to give you the chance to thrombolyze her. It was a massive PE from the word go. Hemodynamically, symptomatically, radiologically, echocardiographically. Did you discuss with her or her next of kin at that time the option for thrombolysis before giving her the tinzaparin and the supportive management? Or was the discussion for thrombolysis left to the point where decision not to escalate came into picture after 233, as you were saying, or showing in your slide? At which point did you discuss with her the thrombolysis option?
So I think the team was, because I was not initially involved in the management of this patient, but initially was discussed. I think the main discussion happened at that time, early in the morning, but initially after the diagnosis, when she was transferred to the ward after her CTPA, I think just the decision was made to just keep her under monitoring, keep her, consider the thrombolysis if she continued to be hemodynamic and unstable. And her blood pressure actually was holding for some time until midnight when she dropped the blood pressure. And that at that stage, I think there was like a serious discussion about thrombolysis. But
exactly.
Yeah, at that stage, she declined that option.
That's my point, Dr. Hind. When the patient keeps walking in one piece after an episode of hemodynamic embarrassment in the form of collapse, I don't know, hypertension, that is the part I missed, with radiologically very evident large pulmonary embolism, I don't know, what does it take to thrombolyze? What is the definition of large pulmonary embolism? And then the patient was decided by the team to be kept on conservative management if she became moribund. I mean, we know when these patients go, they just go. She came giving everybody the chance to be monitored and managed properly with thrombolysis or catheter fragmentation of the embolus. Now, the patient was left until she started to failing, passing urine, blood pressure went down to below 90, meaning this lady of her age, given her morbidities, she was not in her full functional capacity to make a decision of to thrombolyze or not to thrombolyze, meaning it was made this decision to discuss with the patient thrombolysis at the time in her management where she was not in a good shape to make a decision. Do you agree or disagree?
Yeah, I agree with you. But earlier, when after the confirmation with the CTPA, there was a clear discussion with the respiratory team and the cardiology team at that time, and that was the decision.
So
maybe because at that time her blood pressure was actually
can I add something?
stable at that time.
Dr. Mahir Hamid.
Yes, Dr. Mahir. Yeah.
I think a patient like this ideally should have, with the comorbidities, have those thrombolysis according to the morbidity studies and things like that. Because even if you leave her, she was not hemodynamically stable when she came in, number one. Number two, maybe she got comorbidity. She might be, the lady might be worried about the complication of thrombolysis. But this should have been put to her, that the option of half-dose thrombolysis is as efficient as a full-dose thrombolysis. If you remember, when you give a full thrombolysis through when we give full thrombolysis, when we did ISIS 3 and ISIS 4 and things, about 1/5 of the drug you inject goes to the cardiac output, to the heart, okay? And this went to the coronary arteries. While when you give thrombolysis, for PE, the full dose goes through the pulmonary artery. And this is why they came with the postulation that half dose thrombolysis is as an effective as full dose thrombolysis, and with less side effects. And this lady, obviously, I think it's mismanaged, because I think she should have thrombolysis, whatever happened, number one. And even if you keep her there and she did not deteriorate, the risk of pulmonary hypertension will be high in this lady. This lady will never recover. While if you give thrombolysis, Moffitt study and all the studies show that the patient improves, the pulmonary functions improves after thrombolysis more than the people who didn't have thrombolysis. And I think, I don't know why the decision was made at that time not to thrombolyze her, but I don't know the circumstances. But this should be discussed with the family and with her. And what I would have said to the lady, if I don't know what I would have, but no, I shouldn't put my experience here. Sorry, but this lady should have been thrombolized, and she should have given half those thrombolysis. Okay.
I totally agree with you, Dr. Maher, and agree with all the panel members for this and this point.
Yeah, Dr. Hind, I'd just like to say, that it's very good for you to share these cases, because part of it is to learn from experiences. And absolutely. I think it may be more common than we think that actually people may not recognize the definition of a hemodynamic significant PE when the blood pressure is over 90 systolic. And I think that may be the major learning point from this case, is that actually you have to look at all the data and look at the fact that she had syncope, and look at the fact of the location of the pulmonary embolism, the size, and the echo findings. So would you like to continue? I think we've got a few more slides. Is that right? Yeah.
Right. Okay. So early in the morning, and the next morning, of course, the COVID-19 screen came negative. She dropped her blood pressure further, and she was started on IV fluids. Actually, she was given both the furosemide and IV fluids, and her saturation was maintained 93% on 8 liters. Then about an hour or 2 hours later, she deteriorated acutely. Her blood pressure dropped further. Her heart rate dropped to 20 beats per minute, and she went into asystole. And she passed away very quickly at that stage, actually.
Thank you.
So that was the... Sorry, did you want to say something?
Thank you again, for sharing this case. As Dr. Ahmed and Dr. Muhammad, it is a very educational case. And in fact, even, sometimes you compare the care back in home in United Kingdom and here in Saudi Arabia. And you find, there is, although, the guidelines are very clear. If you have an RV to LV ratio of more than 0.9 is an indication. Hemodynamic compromise is another indication. Even yesterday, there was a comment about the raised troponin. And whenever you have raised troponin, I think in a setting of pulmonary embolus, you should think about right side strain, and you should do the echo just to find a way. Actually, you should dig to find a way to thrombolyze such kind of patients, coming to the point of Dr. Maher. This kind of patient, if their thrombolysis was successful early, their future is very good, and their prognosis is very good, in the sense that actually they will not develop markable pulmonary hypertension, and they make very good recovery in a very short time. Again, as Dr. Maher said, half the dose might be enough for this lady. But even if you are worried about that, and in a lot of centers now, they have the echo thrombolysis, where you apply your thrombolysis locally, either in the main pulmonary artery, or you might have two catheters to go to both branches. And the success rate is very high with no side effects from the thrombolytic agent use. It is a very good case actually to discuss, not only just from the clinical, but also from the ethical part of it. And the point of Dr. Safa, which she mentioned, are very valid. And I know you are not, Dr. Hind, you are not involved in the care of this patient. You are a junior at this level, but I think this patient management might put a very big question regarding the ethics, and again, the discussion with the family is very important in such kind of patients. She's elderly, she doesn't know, and again, she's sick to decide about herself. Anyway, thank you very much. We learned a lot from this case as well.
I just want to mention that she had full capacity, this lady. So that's why, the discussion was mainly with her, and the family was involved actually. And before her, she died in the morning. Also, her son was contacted. So the family was contacted, the rest of the family. So she had full capacity, and she made the decision with full capacity, full mental capacity, I mean. So that was what her and that was registered in her death certificate: cardiogenic shock as 1A, 1B right heart failure, and 1C severe pulmonary hypertension due to chronic pulmonary thromboembolic disease. Right. Okay. So pulmonary hypertension is a very huge topic, and I'm just going to talk very briefly, a few slides about pulmonary hypertension, and then if the panel has any anything to add, any comments to add with regard to this topic. So pulmonary hypertension, as we all know, it's actually a group of diseases that can cause pulmonary hypertension or increase in the pulmonary artery pressure. There's a recommendation from the latest update of the proceeding of the 6th World Symposium on Pulmonary Hypertension. It was in late 2018. There was some changes, and maybe the main change is the definition of pulmonary hypertension. Previously, it was defined as mean pulmonary artery pressure of 25 or more. Now it has been reduced to 20 millimeter mercury. So if the mean pulmonary artery pressure more than 20 millimeter mercury, that is considered pulmonary hypertension. And this is according to the right heart catheter measurement at rest. As we know that we have classification of pulmonary hypertension. We have group 1, which is it's actually a group of diseases with subgroups. There is a very nice on the next slide I will show a nice illustration actually published by Oxford Press on behalf of the British Journal of Anesthesia. I will show in the next slide. I just want to mention here that our patient falls in the group 4, which is the chronic thromboembolic pulmonary hypertension, and this category complicates 1 to 4% of patients with pulmonary embolism. Maybe I show this slide. As I said, I borrowed it from as you can see here, the reference is from the Oxford University Press site. So group 1 is a group of diseases, as we can see, including the idiopathic pulmonary hypertension secondary to drugs, and also hereditary pulmonary hypertension. Portal hypertension, congenital heart disease also falls in this group. Portal hypertension secondary to schistosomiasis is also belong to this group. Subgroup of this group 1 includes pulmonary venous occlusive disease and pulmonary capillary hemangiomatosis. We have group 2 as well, which is the pulmonary hypertension secondary to left heart disease, including the valvular heart disease. Group 3, as we know, the lung diseases, pulmonary hypertension secondary to lung disease, including COPD, sleep apnea, and hypoventilation syndrome. Group 4, we talked about it, it's our case. And group 5, it's a multifactorial diseases and unclear causes of pulmonary hypertension. And as we can see, we have hematological, some systemic disorders, including vasculitis, sarcoidosis, metabolic disorders, including thyroid disorder, and others like tumors and chronic renal failure. Just to mention here, and this is a characteristic of group 1, the hemodynamic characteristic according to the right heart cath, if the pulmonary artery wedge pressure is 15 or less, more than 15 or more than 15 millimeter mercury, and a pulmonary vascular resistance of more than 3, in the absence of the precapillary pulmonary hypertension, such as pulmonary hypertension secondary to lung disease, or even the chronic thromboembolic pulmonary hypertension. So this is the characteristic of group 1 mainly. The thing that I would like to mention here, with regard to the management of pulmonary hypertension, is the risk assessment. According to the update from the proceedings of the 6th World Symposium on Pulmonary Hypertension, they mentioned or they stated that there's multiple approaches to risk stratify those patients. And why we risk stratify them is because it will guide the treatment and with the aim actually to reach to the low risk status. There are different parameters. There is the ASC and the ERS, which is the European Respiratory Society guidelines combined together, and with variable, actually they have a like scoring system with, probably I will show in the next slide. And according to the those variables, we would classify the patient into low, intermediate, and high risk. There's also the American system, which is reveal score according to the US registry. And of course, we can, there is a reconciliation of both system to, it depends what system you would like to use, whether it's a European or the American, and you can actually find the equivalent of each system. These are the variables according to the ASC ERS guidelines. As you can see, it includes all the parameters required to assess those patients, starting from the history with symptoms of the patient, the clinical findings of the right heart failure, also the functional capacity according to WHO, functional capacity, the walking distance, the 6-minute walking distance. Also, the variables include the cardiopulmonary exercise tolerance measurement, and the plasma BNP and pro-BNP measurement as well. And we have the echo parameters, the probability of pulmonary hypertension in echo, or also imaging evidence from cardiac MR. And also the parameters include the right heart cath hemodynamic measurement. So this is according to the European guidelines. And with regard, briefly, with regard to the treatment of pulmonary hypertension, the aim is to achieve the low risk status, which means that we aim the WHO functional status or capacity stage 2. The less symptom is the better. So and that's the aim of the treatment. Generally, the treatment is divided into 3 main steps. The general measurements, such as encouraging the physical activity, the rehabilitation, managing the patient also in pregnancy, pregnant lady with pulmonary hypertension, the medications, including initially the high dose of calcium channel blockers and other medication, specific medication, whether as monotherapy or in combination. Also consideration of the lung transplantation. And I would like to mention here, it's very important in patients with a significant pulmonary hypertension, they have to have an expert opinion. They should be referred to the pulmonary hypertension centers. And also it's very important to mention here the role of the multidisciplinary team in the management of those patients. And this team usually include the cardiologists, the primary care physicians, clinical nurses, the coordinator nurses, and the respiratory therapists, pharmacists, social workers, the physiotherapists and exercise physiotherapists. All these teams are involved in the management of this patient. And also palliative care has a role in the management of those patients, because at some stage those patients might be referred for palliation. These are the medications generally offered for those patients. As I mentioned earlier, the calcium channel blockers. We have other medications, including the endothelin receptor antagonist, the phosphodiesterase type 5, including sildenafil, guanylate cyclase stimulator. We have also the prostacyclin analogs and the synthetic prostacyclins and prostacyclin receptor agonists. They're variable medication, whether monotherapy or in combination. And usually prescribed or recommended by the specialist team in pulmonary hypertension. This is just some references if any of the audience that would like to go and have further reading about it. So just briefly about pulmonary hypertension. And now I think I come to the end of my talk, and I will leave the floor for the panel if they would like to add any comments with regard to pulmonary hypertension.
Thank you very much.
As I mentioned, it's a big topic.
Yeah, thank you very much.
Just briefly.
Thank you so much. That was a really great overview of pulmonary hypertension, and thank you so much for sharing that case. And I think it does highlight that there are things that we can do in a non-pulmonary hypertension specialist center to look after patients who have this condition, which is a difficult condition to diagnose and to treat. So thank you very much for that, and thank you for updating us on the guidelines. I wasn't aware of the change in the definition of pulmonary hypertension. Thank you so much for that. I just wanted to open up to the panel. Are there any specific points or questions that we haven't already mentioned so far that they'd like to raise?
Yeah, can you hear me?
Yes.
Yes, I can hear you.
Right. Excellent, Dr. Hind. I mean, that's a very, very real life challenge that happens every day across the world, and still numbers and toll of patients lost due to pulmonary embolism is still very high. And we're looking into ways of improving it. It's almost a mortality on a daily basis. There is a comment. I just want to raise the flag for echocardiography role in diagnosing pulmonary embolism. I mean, it's such a powerful tool for me as an echocardiologist and cardiac imaging specialist. I mean, the first thing when you put your probe on the patient chest and you are faced with such a right side dominance, volume, and pressure overload, there are things that would tell you this is a large, significant pulmonary embolism versus pulmonary hypertension. The first thing you would see, the free wall of the right ventricle is very poorly contracting, but you have to go look at the apex of the right ventricle. If it's a pulmonary embolism, you will find the apex contracting vigorously, the so-called McConnell sign. It's not consistent in each and every single patient with pulmonary embolism, but once you find that, it is such a robust feature on echo versus a very lax, weak, whole ventricle in pulmonary hypertension of a long-standing cause. The second thing that you should not forget to do is to go into the subcostal view. Very often you will find a thrombus traveling somewhere from the pelvis or abdomen or lower limbs, going through the IVC and getting into the RA. If you find that, I mean, I personally, if I find this feature, I will not take the trouble of referring the patient for CT because this is a band-door diagnosis of pulmonary embolism done. Another very important view is get a good short axis, look at the main pulmonary trunk and the bifurcation. Usually, not always, but usually you will see fragments of the thrombus hanging there in the main pulmonary trunk and or its bifurcation. Put a PW across the pulmonary valve and you will see the very nice acceleration time going below 90. All these features combined together, if it's there, I honestly would not refer the patient for CT because diagnosis is made. I would refer the patient, especially if he or she is hemodynamically compromised, straight away for ICU for thrombolysis. If there's no bed, I will thrombolyze the patient there and then where I am standing, be it ER or wherever, even in the corridor, if I'm correctly saying that. Because this is a chance you can cure this disease. It's a curable disease. But the problem is once a patient goes off, is very unlikely to come out in one piece. This is my comment. My question is, what would be your thoughts? It's a hypothetical question. Suppose this lady, she made it. She get over her acute pulmonary embolism, which is obviously an exacerbation of recurrent episodes of chronic thromboembolic disease. How differently would you treat her? I mean, obviously she would not be a straightforward anticoagulation. No, this is a disease. We know the CTEPH is a disease which is between two brackets curable with your real SIGWAT. So what would be your thoughts of how differently you're going to manage this lady if she made it?
Do you mind if I answer that question? Is that okay? So I think that's a very good question. And so the way I would look at it is she's had an acute PE. So I would put her on anticoagulation following thrombolysis. And then I would refer her to the pulmonary hypertension unit. And in the UK, we have a centre in Papworth who specialise in surgery, which is a thrombectomy procedure for patients with CTEPH. And that is, as you mentioned, it's a curative treatment. And it's actually been shown to improve, to cure CTEPH. And it's the only real curative treatment for such patients with pulmonary hypertension. So in the UK, certainly we would refer those patients on very quickly for assessment at a super specialist centre such as Papworth.
Adlan, you are privileged to work in a place where you have Papworth, or you can send to San Diego. The three places I know of, San Diego and Papworth, and a big center in Bangalore for cardiac surgery. But what about advice for the rest of the world? That's why the real SIGWAT is made for, between two brackets, the no immediate option for surgery for these patients.
I think you're absolutely right. And in fact, you would be in a better position than us to comment on that, and in terms of experience. So really, we're here to share your experiences and to learn from you as well.
Abdullah.
Can I have just, first of all, a comment about Dr. Safa, and then some questions for Dr. Hind. Regarding the CT, Dr. Safa, we are in an era where litigations, I know you are concerned about the patient safety and the patient prognosis. But again, if the CT scan is available, I think we should do it, because you cannot thrombolyze the patient just based on your echo. Yes, your echo make the diagnosis, probably it might help you also to make the decision. But I think we have to have, if we can do the CT scan very quick, we should do it. My question to you, Dr. Hind, and Dr. Ahmed, yes, Ahmed, you have the privilege to actually have these centers, but even in the UK, I don't think they are, available nearby. And this raises the question, Dr. Hind, what are the updates in the guidelines regarding endarterectomy is one, number two is the use of balloons on chronic thromboembolic disease. This is for us as interventional cardiologists. And the other thing is these guidelines, is there anything about the 6-minute walking test? Is it still done or not?
You mean the updates with regard pulmonary embolism? Because there is a recent update with regard to the pulmonary embolism from the ASC. Are you talking about the pulmonary embolism guidelines or the pulmonary hypertension guidelines?
Yeah,
because for pulmonary embolism, there is in the guidelines there is clear mention for referring patient for surgery if they are suitable for this procedure. So definitely from the guidelines is the clear indication that for such patient she should go for endarterectomy if that would be the suitable procedure for her. But with regard to pulmonary hypertension, it's a question about regard pulmonary hypertension guidelines, you mean?
Yeah,
That's your question.
Walking test, yeah. But just regarding, because we have a discussion about chronic thromboembolic disease in our cardiology group as well, and most of the surgeons, they said actually you have to have a dedicated centers, and you have to have even the surgeons. There is a big difference between the different surgeons, and the prognosis depends on the surgeon, and probably. I'm just saying where I am here. We don't have even a single one who is doing this kind of surgery. So, is there any place for balloon angioplasty for this kind of patients or not?
Yeah, I think there is a place. Yeah, from the guideline, there is a place for the surgery and the endarterectomy and the even balloon, but I haven't seen a patient actually from my own experience that referred for such procedure. But presented to us, and we refer those patients for those centers. But I have, I've seen a patient who had such a procedure before in one of the centers in UK. I think it was in Cambridge. So there is a centers and there is a place for this procedure. But
can I comment?
To be honest, it's not very not many centers they do it, and it's quite limited.
Yeah, I think Dr. Bedri had a comment.
Yeah. Okay.
Thank you. Just a comment, actually, just trying to answer what Abdullah is trying to say. In the recommendation of the WSPH in 2018, they mentioned about the interventional strategies in the management of pulmonary hypertension. They mentioned about 2 or 3 options. One of them is a balloon dilatation. But I think that is not, I don't know about the centers in UK. Long time when we were working here, we used to refer our patient to Sheffield for the diagnosis of pulmonary hypertension, because that is something which should be done in a tertiary center with all the facilities and all the ability to diagnose pulmonary hypertension. About the intervention procedures, they talk about the percutaneous balloon arterioseptostomy, which is just either like, just for bailing out or palliative management bridging for a transplant. And that is actually going down now in the recommendation. The other things about the endarterectomy surgically, which is highly recommended, and I don't see whereabout in UK they are doing it, but still there's a place for percutaneous balloon dilatation if patient deemed not fit for surgical intervention. Sorry, are you hearing me?
Yes, I agree with you. I agree with you. In the guidelines, there is a place for such procedure.
I know that.
I'm
short. The most important thing about something which you should mention about the percutaneous pulmonary artery denervation, which is coming now, and I think that there's a lot of evidence now. If you do a percutaneous pulmonary artery denervation for pulmonary hypertension, that will be helpful and there's a number of reports going around. I think that this will be also a breakthrough in the management of pulmonary hypertension. But the surgery is available.
Thank you very much,
Yeah.
Dr. Badri, and thank you very much, Dr. Zain. We're going to have to stop this session, I'm afraid.